Hello, everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and for parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm the mom of a preemie, 28-weeker, and a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also really well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or a family, I'd invite you to head over to their website, canadianpreemies.org. There it is on the screen, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. You'll also be reminded that CPBF is a charitable foundation. And so if you're someone who this time of year you purchase gifts for people in your life who you love, then we'd invite you to consider giving a donation in someone's name, just a meaningful gift this time of year, and helps families who are in NICU as well. Today's session is live, so we'd invite you to bring your voice to the table. The more people who participate, then conversation is generated. So let us know where you're watching from. It's always interesting to see where people are tuning in from. And it's through these rich conversations like the one that we're going to have today that practice can advance and we can learn together. So please participate and let us know where you're watching from today. Now, as the mom of a preemie, this statistic can be a difficult one to swallow, but infants who are preterm experience an average of 12 to 17 skin-breaking procedures, such as heel lances, a day in NICU. And repetitive early pain exposure can actually change how a preterm baby's brain develops. And so looking at the management of infant pain in NICU is a topic of great importance to both parents and healthcare professionals. I'm so pleased to be joined here today by Dr. Rebecca Pillai Riddell, who's going to be leading this discussion. She's been studying infants and caregivers for over 20 years. Her team has just completed a large-scale Cochrane review of 138 different studies that look at different non-pharmacological approaches to managing pain in infants. In this presentation, she's going to talk about the importance of skin-to-skin and other new emerging strategies that have the strongest evidence-based for managing pain in preterm hospitalized infants. Dr. Pillai Riddell is the Tier 1 York Research Chair in Pain and Mental Health and director of the Opportunities to Understand Childhood Hurt Laboratory, or the OUCH Lab, in the Department of Psychology of York University in Toronto. She's also a registered clinical psychologist focused on work in perinatal mental health, infant mental health, and chronic pain. Dr. Pillai Riddell is a fellow of the Canadian Academy of Health Sciences and a member of the Royal Society of Canada's College of New Scholars, Artists, and Scientists. She was also recently awarded the 2020 Canadian Pain Society's Outstanding Mentorship Award and the 2019 American Pain Society's Jeffrey Lawson Award for Advocacy in Children's Pain. Rebecca, thank you so much for joining us here today.
Thanks so much for having me. It's my pleasure.
I'm going to put your presentation up and just hand the reins over to you because you have some interesting things to share with us today.
Fantastic. So thank you, everybody, for joining in. I'm joining in from Toronto, Ontario, Canada. What I'm going to be speaking to predominantly about is this Cochrane review, but wanting to first start with other strategies. And all of these strategies are really meant to be able to empower parents to know what they can do to help their babies in the NICU. So as Leah said, pain in the NICU is pretty overwhelming. Babies are receiving 12 to 17 skin breaking procedures a day. For almost 20 years, we've been exploring the type of pain that premature infants are experiencing. And we realized, so a lot of my research was originally done with healthy babies and parents through vaccination pain. And that context is very different than the way infants receive painful procedures in the NICU. So we know that first, they have bigger painful procedures post-surgical. So after many surgeries they'll have, so that takes longer than just the initial kind of heel lance or a needle poke. And then we talk about, we've been experimenting with the concept of this chronically pained infant. And so it's the idea that they have so many painful procedures in a day, they don't actually get to recover from one. So having a heel lance, for a preterm baby after they've had many heel lances isn't the same as having a heel lance when a newborn healthy baby is born and they only have that one lance. And then we're also exploring, I'm a part of a global effort to build a definition to understand chronic pain in infants. So in older children and adults, we kind of used to define it as greater than 3 months. Well, for babies who haven't been alive that long, that sort of marker doesn't make a lot of sense. And so we're currently underway. We've had a publication come out recently, a couple of years ago, where we came together and we're continually trying to refine that definition with scientists from across the bedside to bench to bedside spectrum. But one of the key pieces to understand as we go through this is that this is overwhelming, but parents have the power to moderate this pain. And in fact, in many times, parents are the best people to help moderate this pain. One of the fears that parents have had when we've been talking to them about managing pain in the NICU is that if they're there, if, for example, the baby's in skin to skin, the baby will actually associate the pain with the parent. And that's absolutely not true. The idea is that when a parent holds their baby in skin to skin, it's actually coming to a natural state of being. And attachment research shows that actually that's when babies need parents the most, is during painful and distressing contexts. So being with your baby when they're going through painful procedures is a great place to be. And it will not allow your baby to associate you with the pain. Uh, Everything we're going through, I think that these are ways to empower parents, but it's just important to collaborate with medical experts. So preterm babies are like snowflakes. They have very different medical conditions, and that changes day to day. And so the idea of using all of these strategies or trying to attempt all of these strategies may not be right for your baby. So it's always important to check with the medical experts that support you to try. But this will empower you to know some options that you may be a part of. So no surprise, we're going to start with skin to skin. Last week, I was pleased and honored to be a part of the Canadian Premature Babies Foundation Salute, World Prematurity Day, about celebrating skin to skin. And evidence does suggest that it works to reduce pain surrounding acutely painful procedures. And so when I use that word acutely painful, it means something like a heel lance. So something very short and time limited. But what I wanted to do is, because I feel like I'll be preaching to the converted here if I talk too much about what skin to skin contact is. You can kind of see the picture in the back about holding a diaper clad infant about 60 degrees. So there's a bit of a slant. So, gravity is kind of holding baby close to parent. But one of the things I wanted to bring up, and this is in pilot data, because we are grateful to the Canadian Premature Baby Foundation for partnering with us to support a grant that we're hoping will get funded by the federal government. But it's the idea of how to improve skin to skin. And so one of the things we've been exploring is the mental health of mothers being put in the situation of doing skin to skin during something that's very traumatic for them. And while we know that skin to skin is great for mom and for baby, there is sometimes stress involved for parents holding their NICU baby in skin to skin. And so what I wanted to just touch upon and focus on a little bit is evidence that the moms gave us. So these, I'll be talking a lot about data and a lot about research But I thought I would ground our conversation or start our conversation in the evidence from moms. Moms just like yourself, if you're a NICU mother or a parent, who have gone through this process and have had some years to think back and reflect on doing skin to skin in the NICU. And some of the evidence, some of the recommendations moms gave was that when professionals are introducing the concept of skin to skin care, which is kind of this continuous long term approach to caring for the baby, where the baby's in skin to skin as much as possible versus what we're talking about today is skin to skin contact during painful procedures. Parents wanted us to make sure that we communicated that you have to be careful for health professionals to be careful about how they communicate to parents, because parents feel really guilty already. There's a lot of guilt that they go through from being a NICU mom. What did I do or what did I do to cause this, for example? And the idea that even if it's not true at all, the idea of triggering guilt in them by saying, like, this is important, you have to do it, rather than kind of thinking about the mother and the baby as both having, this is great for both, and thinking about not triggering that guilt. Asking parents about how to do skin to skin, like what stressors or what are they scared of. We were able to generate a long list of things that parents are scared of. So things like disrupting the tubes or monitoring equipment. What if the baby desats? The baby has desatted many times in front of us, and so I don't know if I'm the best place for my baby. But just having health professionals dialogue about that. Addressing up front, what if a tube comes out? What if a monitor comes off? What would they do? Because this is one of the big fears parents have. And if they set it right up at the front, it may reduce stress. Sometimes parents are so overwhelmed, they don't actually want to talk to someone. And so there are times where they want to talk and learn about skin to skin, and other times where maybe it would have been nice just to have a card by the incubator, left a brochure, or having a video that they can watch at the same time. So having different options, because being on the roller coaster that is a NICU stay, where there can be highs and deep lows, the idea is that that information can get to them depending on where they are. They also talked about when you're wanting to put your baby, getting a parent who has stress about skin to skin and fear that they're going to hurt their baby, maybe this idea of doing graduated touch. So rather than going straight into skin to skin, getting them used to gradually or gently touching the baby, being able to do things like hand hugging, to make them feel more safe and more confident. Because many parents reported they didn't have any experience with any newborn babies. And to have a NICU baby with special needs and all of the equipment, the necessary medical equipment, makes it very overwhelming. And the other thing we were talking about, and this has to do a bit with the grants that we're hoping to get funded for, is just the idea about improving skin to skin by improving maternal mental health. And so they had the idea of teaching parents to relax with music or meditative audio. So kind of thinking about a podcast that relaxes you, or some music, or guided imageries that you can download, or like an app that has some meditation music. And the idea is to get your heart rate and your breathing regulated so that you feel calm as a mom before you go into skin to skin, because we believe that that optimizes skin to skin contact. So I think it was mentioned earlier in the introduction about this massive study we did. To our knowledge, we think it's the largest systematic review of non-pharmacological approaches to infant and young child pain. So we go all the way up to 3 years, but we have one section of our review that's dedicated to preterm babies. This was based on 138 studies, over 11,000 participants. And the most common type of acute or this short-term procedural pain was heel sticks and needle sticks. One of the problems, and I want to bring this up as a caveat, that this is a lot of research, but the quality of the research, and there's one specific type of research study we look for, and it's called a randomized control trial. Without getting into too many details, what it allows people to know is that the effect of a treatment, like skin to skin care or all the other treatments we're going to talk about, is really due to that treatment rather than other factors. And so when we do these articles, we don't just read the article, we look at the quality of the method that they did. And so it's really important to point out, sadly, that of these 138 studies, the vast majority of them have resulted in us having very low to low certainty. So there is evidence, but right now, our certainty in the evidence, and sometimes it's really hard because one of the qualifications to have a really strong, high certainty rating is that everybody is blind. So the mother would be blind, the investigators would be blind, the people who code the data become blind. And that's really just not possible in the types of non-pharmacological interventions. It makes sense when you have drugs. You can everybody doesn't know what's in the special vial. But when it's something like skin to skin contact, it's hard to blind a mother or a caregiver from that being skin to skin. So kind of the two sides to weigh as you go through is that, yes, the evidence, the certainty because of this quality indicators for randomized controlled trials suggests that the evidence isn't at the highest level, but understanding that in the type of science that we're doing, it doesn't fit the box well. For health professionals who are interested in this 377-page document. To me, there's only one, there's two important pages. It's about page 360. It's the supplemental table. The Cochrane is a very formalized process of distilling medical research in the highest, with the highest accountability and transparency possible. But ultimately, honestly, it takes forever to get these 377 pages together, but 2 pages are of importance. And that's the supplemental table 1 that's on page 360. So if there are health professionals out there, that's where you're going to get a whole, I just summarize everything. My team and I summarize everything. We divide it by age, by strategy, and you get the size of the effect. So I'm going to start with the first one, non-nutritive sucking. This is a pacifier. The reason we don't just call it a passy or a pacifier is because it's the idea that there's nothing on it. So there's no sugar, there's no sweetness on there, sucrose, nothing sweet on there. And what you're going to see as we go through is that in the corner, I'll always remind you about the certainty of the evidence. I'm not going to keep saying it over and over again, but it's just to remind you about the quality. And the lowest level is very low, and then it goes to low, then there's moderate, and then high certainty in the evidence. And the other thing in that little black box you'll see is the size of the effect. And so the higher the number, the bigger the effect. And that means the bigger the difference between babies in pain who got the intervention versus babies in pain who didn't get the intervention. And that's how we compare them. And we look at pain scores. There are different ways to what that means, but it's often looking at the baby's face, their body activity, their heart rate, and their oxygen saturation. And so we most of the time, you're putting all of those together and you're getting a kind of what we call a proxy judgment because babies can't tell us that they're in pain or not. And that's how we measure pain. So when we talk about these numbers, the higher the number, it means the greater the difference between babies who received the treatment versus who didn't. And so with non-nutritive sucking, the idea of sucking on a pacifier, when a heel lance happens, for example, or a kneel stick, we see that the strength of the relationship is moderate, but significant. And then the idea of the certainty comes into play. And that's, again, about the evidence base. Swaddling. So this is where you're taking a child and you're using some sort of cloth. It can be an actual bundler or it can be blankets that can actually contain the child. So it's really that the key element here is containing the child and bringing extremity to trunk and bringing them close in. And one of the things I wanted to bring up is this idea of reactivity versus regulation. So when we think about pain, we think about the immediate reactivity, and that's like within 30 seconds. It's that peak response. So if you think about yourself and you're waking up in bed and you go to the bathroom and you come back and you stub your toe, that initial reaction is reactivity. And the regulation is how you come back down to how you were before you even stubbed your toe. And that's how you regulate or come down to kind of what we'll say baseline or normal levels if we want. And so we separated the two because sometimes you'll see that interventions work better with that initial reactivity. It actually somehow affects how the organism is expressing or experiencing the pain, like how the baby is experiencing it immediately, that big shock at the beginning. And sometimes where you'll see the effect isn't necessarily in making that initial reaction lower, but what it does is it allows the baby to calm down quicker. Okay, so when we talk about reactivity, it's about the initial, and we talk about regulation, it's about calming down and calming down quicker. And so with swaddling, you'll see that I added a little question mark here, and this is all the complexity of Cochrane, but that's where, while we have a moderate magnitude, there was so many different findings in the studies that we averaged together. The actual result wasn't reliable. And so it wasn't reliable, I think it is the way. So whenever you see a question mark, while it could have a really big magnitude, which we want to report, meaning it was moderate, a moderate difference between babies who got swaddled versus not, it's still the error or the way we kind of sum it over, we don't believe that it's statistically significant. But what we do see is regulation. So this is a very large effect size. So what we're seeing is that with swaddling, if you pull their heel out and you lance the heel, you still get the same initial reaction, but they seem to calm down quicker. Facilitated tucking. This is also known as hand hugging, and you're still getting the containment, but instead of using a blanket, you're using your hands. So children can kind of have that tactile response, the warmth and the heat, and particularly with mothers or fathers, like the smell of the caregiver. And the goal here, the active ingredient is containment. So trying to make the child feel secure. And what we see is that when you're doing, for example, a heel lance or a needle poke for reactivity, a very large reaction. So that initial reaction, it seemed to have a really great effect. And with regulation, a moderate effect, and both of them being statistically significant. For touch and massage related, so the idea is that there's some sort of movement in the hands. It's also known as gentle human touch. It can be stroking. Those were all the ones that we sort of related in here. And the idea is that for both of them, doing this during a painful medical procedure is a very large effect. We see a lot of effect sizes, almost exceeding or approaching 1. And we remember that a large effect size is about 0.8. So there's a really big difference. We think that for this one, it's because it provides sort of, not only is it cuddly and nurturing for the baby, it's actually providing with the movement some what we call counter stimulation in the brain. So it's actually kind of interfering with the pain signals getting up there, and so it's actually helping moderate pain. So sound addition. So this is the idea of trying to replicate what it's like to be in the womb. And so some of the sounds that they've tried is things like maternal heart rate, maternal voice, and maternal voice as if it kind of estimating what it would sound like from maternal voice in the womb. And so the idea is these additions of sound. It could also be lullaby. And so, but most of them are looking at sounds that kind of compete or replicate heart rate or the sound of blood, like gushing through veins, like that white noise, voice, things like that. And what we see is that right now, where the research is at, it feels like reactivity or the evidence is suggesting that there is a high effect on the initial reaction, but we're not sure about the regulation. And again, this is about the idea that there's not statistical significance, but we are seeing this high magnitude. So again, it's something worth suggesting or worth trying, but knowing that there's a lot of variability in the results of studies that do this type of work. sound reduction. So this is the idea of applying sound, taking away sound, the exact opposite, to help the baby have a more peaceful womb-like experience for these preterm children. And so there's been a lot of research on sound reduction, period, but in sound reduction specifically for pain, what we're seeing is that while there's a moderate effect size, and there are a couple studies that have done this, the idea is that it isn't statistically significant yet. And so, the jury's a little out on this, but the idea, I think, is that potentially this could be something to try. And there hasn't been any research on the regulation. So it's just about that immediate effect. Smell addition. And so this is the idea that babies' olfactory senses are developed. It's one of their most developed senses when a preterm baby is born. And thinking about if you added a sense of something, a smell, could this work? And so there were a lot of different studies in there. And so we kind of lumped it all together. But what I wanted to point out was that they both seem to be effective. And there's not enough data to say whether one type is better than the other. But some of the smells are more reminiscent of the mother. And so the idea of taking a cotton pad and putting mother's breast milk or mother's amniotic fluid from delivery and putting that smell near the baby versus what we call kind of not non-familiar smells, which are like lavender or vanilla. So smells that adults would find more soothing, and finding that is working. I think the idea, though, is that for all of these smells, and it's easy for the amniotic fluid and the breast milk, is that the baby is familiarized with the smell. So they're getting to be relaxed with the smell and making those associations so that when they do go through the painful procedure, it kind of helps them remember that relaxed state. So you're not just springing it on them, but they've had some what they call familiarization with those smells. And again, approaching moderate, small to moderate effects. The other one, another type of way of modifying that parents could try or suggest to medical health professionals is light reduction. So again, all of these things come back to the intrauterine environment and trying to think about things that may be more soothing for a baby. So they've looked at if giving a child a painful procedure in light reduction, and the researchers kind of used two different. They kind of cover the infant's eyes in some way, or actually doing it in an incubator that is covered, so it's just darker, less stimulation to arouse or irritate the baby, and then doing that heel lance at that moment in time, or that needle prick. And so these are pretty large effects, they're approaching large to very large effects, with that idea of reducing light, being good for both that initial reactivity and even larger for allowing the infant to regulate better. So getting to lower pain scores or back to normal quicker. And then we have multisensory interventions. And this is where you're combining a bunch of things. And so this is a picture of a baby being held, having the pacifier. There was gentle human touch happening, and a lullaby was being played while the mother kind of hummed along. So really just trying to put it all out there, the heel kind of sticking out at the end, which it didn't show, but with a lancet. And so what we're seeing is really large effects. That in the number of studies that have been done, we're seeing very large effects with this being able to reduce both the initial reaction. You see a much bigger response, but these are all large effect sizes right after the heel lance or the needle, and then actually how quickly the pain scores kind of come back down after the needle or the heel lance. Another thing the final one I wanted to just bring up was this idea of combinations. So people are trying to think about what are the most reliable ways to manage pain, and then what if we combine some? And so one of the combinations that's most commonly done, because we need multiple studies to be able to include them in here, was combining things like a pacifier and a swaddle, or kind of touch and a swaddle, and sucking, all these sorts of things to kind of combine with the sucking. And we're finding that if you remember at the beginning of the talk, they were moderate effect sizes of sucking, pretty good ones, like I think around 0.6. But when you add others, there can be additive effects. And so you're seeing almost the power of or the difference between when you're just doing non-nutritive sucking, which is good, to even higher or larger effects for that reactivity and the regulation. So the idea of combining non-nutritive sucking with other interventions being very powerful. I just wanted to acknowledge the lab that helps me get all these big, huge studies done. I'm so grateful to them, and particularly Wana Baksha. She's a PhD student, actually a very close to, she's in her 3rd trimester now, giving birth to her 2nd child. She was really the driving force between this version of the Cochrane. It's our 3rd version, but it was a substantial addition of, I think, almost 75 studies. And so grateful for your time, and I'm excited to take any questions.
Thank you so much for that presentation. It was very interesting to, I liked your little box that was talking about the certainty of evidence, because I think so often, we have this idea of what works without that level of certainty, especially in neonatology and working with preterm babies. So I just wondered, it looked like only one of those had moderate certainty. Is that correct?
It
Was I
is.
right in spotting that?
Yes.
So
Yes.
would it be your opinion then that that's what people should go with, since it's moderately certain, or is it something that we really can't say until it's been studied more?
Yeah. So again, it's a lot about the factors that are involved in how we judge the certainty. It's about the science and the methodology. And
Mhm.
what the ideal study is like you have 2 exactly identical groups of people.
Yes.
Identical, right? And then only one group gets an intervention, and then the other group does not. And
Right.
so then you can say, yes, the difference between the groups, and the differences within a group, because we have these 2 groups of people who got skin to skin and people who didn't. But then you want to make sure all the people in the group that got skin to skin are the same, and all the people
Mhm.
who didn't get skin to skin are the same. And so that's not the reality of NICU care. Every day can be different, and babies develop very rapidly. And so if you're not able to, and it's very hard to do this kind of research as well. Parents are in a very difficult challenge. We're in Mount Sinai right now, collecting data. And so it's a very delicate, we know we've been there for a few years trying to collect this data. And so it's a hard population to get. So often what happens is that you'll have babies from a large age range. And so in premature, times like 6 weeks, massive differences.
Yeah.
Where, with an older baby, a healthy older baby, if I was comparing a 2-month-old to a 3.5-month-old, people aren't going to be kind of, looking too closely at that.
Right.
But that's often the reality of a lot of the research we do. And so that confidence in our results gets lowered
Mhm.
the more differences there are within a group. And they really do try to have those differences counterbalanced. And that's part of the method I was talking about in a randomized control trial.
Right.
Because you kind of hopefully randomly assign this baby goes here and this baby goes there to kind of reduce those differences. But
Mhm.
it is really hard. So in my opinion, when we're seeing, because so much of the research does support in a magnitude sort of way, I think the idea is that there were like very little adverse events across 135 studies. So these are things that we're pretty confident are not harming children.
Mhm.
Um, and so we do think that most of them help, but it's that idea of your own special snowflake and kind of thinking about in the context, like where the tubes are, where the last surgery was. So, a child who's had open
Right.
heart surgery going into skin to skin is not the same, as a small for gestational age baby
Mhm.
who's born premature going into skin to skin.
Right.
So I think that's that this allows you to kind of look at, I feel like the Cochrane almost provides an inventory and a
Right.
summary of what's been done and things that you could talk to your medical professionals to see if, it's valuable. But even things that we know, like just thinking about the research on light or sound reduction, even outside of pain, we know that these are important aspects, but not the majority of NICUs aren't able to keep like sound at that reduction
Right.
or light at that reduction all the time. So, I think that the American Academy of Pediatrics is that below a normal talk should always
Hmm.
be. That's the way, but it's very hard to maintain this in, a NICU environment, and with monitors and alarms and all of these sorts of things.
Yeah. We do have a question from the audience from Sabrina. She's watching from Montreal. She
Hi.
said she's the
Bonjour.
mom of a thriving 25-weeker who's now 4 years old. So she said, "Thank you so much for the talk. My question is out of the scope of your review, but do you know if there is solid evidence of the effects of pain in the NICU on pain regulation in the toddler years?" Good question.
Great question, and I wish I could answer it with a lot of evidence. The challenge, so um, actually, like a lot of this research, and we call it longitudinal, meaning long-term follow-up,
Mhm.
has been done in Canada. And so there's a lab in Vancouver, Ruth Gruneau's lab. That's who I'm sure she or her colleague Stephen Miller have probably been here at one time or another. So they've done longitudinal research, but not in pain contexts.
Mhm.
And so the idea of following them up, what they do see is that there can be differences towards how children have physical experiences, so sensitivities, and feeling uh, illness in their bodies or pain in their bodies, that there can be differences with premature infants and how they process touch in different ways, but it's hard to kind of pinpoint exactly where. Um, my lab has created the largest cohorts in the world for healthy babies. And so, what we have seen in the vaccination context is that early interactions between caregiver and infant does have relationships with how children regulate pain as toddlers and older. Like we went all the way up to preschool. So there are relationships, but I think the idea is that it's very hard with the complexity of the NICU because we would never put babies in pain unnecessarily.
Right.
And so in the pain context, the study, and we're hoping to get there, we're hoping to get there, would be, following parents and babies in the NICU, and then kind of doing our study, following them up as they age through vaccination pain.
Mm.
So that's the dream study that I hope to one day be able to do.
I was wondering when you were going through the different methods, if there was a way. So we were talking about swaddling, the non-nutritive sucking, the everything, the massage, all of that. Was there a way for you to determine if there was a difference when the parent or someone who loves the baby was present versus when it was done by healthcare providers? And do you think we would see a difference in baby's response?
Yeah, so none of the other procedures have been done. They didn't control parental presence.
Mm-hmm.
So I couldn't say that per se. But there has been research looking at pain with alternate caregivers versus parents. And the research that I saw in Celeste Johnson's Cochrane, I was just looking at it today, suggested that, for pain, whether, being in skin to skin is equally effective for if you're with a caregiver versus an alternative caregiver.
And what about versus healthcare provider versus caregiver? So, like, if the healthcare providers were providing the, I'll say pacifier, I didn't know what word to use,
Yeah.
or, swaddling baby, would baby have the same response then to pain? Or would it be different if a parent was present doing that intervention for the baby?
Yeah, I think it would depend. So I'm going to kind of depend on good old fashioned, like a capital A attachment theory research on
Mm,
that. And so I would say that with it depends, because the other thing that we're realizing and trying to control for in our future studies that we're collaborating with the Canadian Premature Baby Foundation is actually looking at mother, like how much they're at bedside as well.
mm-hmm.
And so we can't assume that a parent is a parent is a parent. This is the idea of all the
Right.
unique situations that come through. There are some parents who can only come on weekends. They have other children, they have to work to support. They live very far away, sometimes, 300 kilometers. From the NICU that they ended up having to go to the level 3 to get a level 3 kind of sort of care. So it's complex, because from an attachment perspective, what I would guess, what I would hypothesize is that the more the mom and baby have been together outside of painful context, the more powerful their presence will be.
Mm,
And so to kind of apply it, like, so non-nutritive sucking is really just putting a pacifier in. And so if the parent isn't, if the baby doesn't know the parent is there, if they kind of sit and then they're just waiting, for the child to wake up, or, they're there, it's very different than when the parent is there doing hand hugging or just
mm-hmm.
talking, just talking to the baby. And so the voice, so you start seeing this different layer of what the parent is doing. It's not just the presence or absence. Because unlike older, like if we were doing it with a teenager, the parent just sitting in the corner of the room may be helpful or not, maybe a peer. But it's the idea that they know they're there, and that brings a sense of
Mm.
security. But a preterm infant isn't capable of knowing. They don't have object permanence to think that the parent would always be there, if they can't smell them or feel them. So it kind of it depends.
Along the same line, I had a question about skin to skin as well. And so we've talked about this a lot, especially with the theme of World Prematurity Day, about skin to skin often and early. I'm wondering if it's been looked at, the difference between, I guess I'll say, actively engaged skin to skin versus passive. So you talked a little bit about maternal mental health, and the importance that may play in skin to skin. But what about, we're seeing more and more electronics, for example, being in NICU, of people being allowed to have their phone. Is there a difference of doing skin to skin with a baby and looking at your phone versus doing skin to skin with your baby and being engaged with what is happening with your baby?
So I think that there are two effects of skin to skin we always have to keep in mind: effect on mother and effect on baby.
Mm,
Because the World Health Organization and lots of researchers have shown that there are positive effects both ways. From the baby's perspective, if what they're doing on the phone is actually relaxing them, so I'm imagining, watching, a show that makes them happy, or they're talking to their daughter who's not in the NICU, or something that they find relaxing that the baby could pick up on via heart rate, for example,
mm,
feeling the speed of the heart rate. I think that would, it could enhance actually the effects. For the mother, though, or the father that's doing it, being distracted and being out, I think impacts being present in the moment, because we talk about those love hormones like oxytocin.
mhm,
And
mhm.
I think that from the parent perspective, and I don't know any research studies that have kind of examined any of this, and how this could influence it. And in our study right now, where babies are in skin to skin during painful procedures, there are no phones, because we're actually measuring the baby's brain activity as well. So everything is very controlled as much as it can be in the NICU, to kind of look at that. So I think that from the infant's perspective, they're still going to have the soothing heart rate, they're going to have the heat, they're going to have the smell, they're going to have the touch and the warmth. Um, and from the parent's perspective, I think is where it could interfere, because it's that idea of not relax and getting, because those are some of the moments of joy of
Mm.
finally getting to hold, parents describe me, finally getting to hold, feeling like a parent. And so I could see, just the perinatal psychologist in me, not the scientist, how parents who are really keyed up, and our pilot data is suggesting there's a small group of parents. We interviewed 7 through the CBPF, but the idea that like 2 of them were never relaxed
Mm.
during to skin, even through level 3 and level 2. It made them feel really anxious and nervous. And so I think the idea of being on the screen for them may have a different
Mm.
effect in terms of feeling, attached and wanting to, and you thinking about not being able to relax and shut down a little bit, like just to turn it off and just enjoy the moment.
Mhm. We have another question here from Sabrina, who says, do you have a knowledge transfer plan across Canadian NICUs for the conclusion of your review?
Yeah, so the review just came out, and this is the beginning. This is my third. I've been working on this for 12 years. And so if you go to Sick Kids Pain Hub, if you just Google Pain Hub Sick Kids, you'll see that we went in partnership with About Kids Health. And so we have handouts for parents because none of our findings significantly changed over the course of the 11 years. There's just been more and more evidence kind of accumulating in different areas. So I'm also very open to giving other talks like that. But in terms of trying to get this into NICUs, that's been our main strategy. But we definitely want to think about, we're definitely thinking about trying to do summaries that we can get out via social media as well.
And that was going to be my wrap up question. Just what's next for you? You kind of mentioned, the more in-depth study, but if you could dream big, where would you like to see this all go within the next, let's say, decade of neonatology?
I think if I could truly have my dream study. I've pitched it right now. It's when I say the government, it's the Canadian Institutes of Health Research, and we're looking at the outcomes of the baby in the context of the outcomes of the mother, and
Hmm.
really centering mental health of the mother. Understanding that it's not just good for the mother, but it would impact infant outcomes. And so the study that we're proposing is actually to kind of measure the stress that a mother is going through, looking at their heart rate and the baby's heart rate and how they regulate together, which is kind of the ideal way. Developmental psychology has kind of taught us that, when mother and child are going through something stressful, what you hope is that mother regulates and then kind of brings the child with them, brings the baby with them. And
Mm-hmm.
so what we're expecting to see, or what we hypothesize, is that there's a group of mothers who are in the NICU who are very stressed, who even when in skin to skin, it may not be as regulatory. It's always good, but it may not be as optimized for the mom or the baby. And so if we could get evidence to show that, that's a big impetus and big evidence to actually start supporting mothers' mental health more significantly for
Mm-hmm.
people who have significant issues with anxiety, trauma, all those sorts of kind of more serious things that can be triggered by the chronic stress that is that the NICU stay is. And so that would be my dream, to be able to. I'm perinatal clinical. I have a small clinical practice in Toronto, and so in my practice, I focus on the mom. In my science, there's a lot of focus on the baby, and so if I could dream, it would be kind of putting them together to understand that mothers and birthing parents broadly, that if we support both, because there needs to be intensive intervention for mothers, psychological interventions for certain mothers, especially if you had a trauma history, if you've had histories of anxiety or depression, not kind of acknowledging that type of treatment should be primary care.
Mm-hmm.
Where right now, from my understanding, and there may be units that differ, but right now, that higher level of psychological support just isn't possible. They just don't have the capacity. And so it's about proving to governments, to proving and providing the science about how this not only helps mother, but baby. And if
Mm-hmm.
my guess is like not just in the NICU, but beyond. and thinking about how, because we're often seeing this cycle that, moms are really stressed, but they don't have time to really
Right.
think about it in the NICU. And then they get home and they're really stressed because they don't have the NICU care anymore and they have to figure this all out. And then it sort of starts to hit.
Mhm.
The mental health challenges, the trauma, the depression, those sorts of things can start to, because, as they take away the acute stressors, this long-term eroding of mental health starts to catch up.
Mhm.
To think again, if you take them both and you prioritize birthing parent, mother mental health at the same, alongside baby in the NICU, because it's not just about the NICU, it's the life after.
Right. Right. Well, thank you so much. There are exciting things on the horizon, and so I appreciate you sharing your wisdom with us today, and we look forward to hearing where this all goes as you continue down this path of discovery. So thank you so much for
Oh,
joining us today and for sharing.
my pleasure. And thank you again to the CPBF for supporting this research and being patient partners with us so that we can learn and kind of work together to make this better.
Thanks again. And thank you, everyone, for joining us today for this edition of Preemie Chats. If you have missed any part of it, then you can head over to the website, canadianpreemies.org. We want to thank the sponsors of today's chat, AstraZeneca, in collaboration with the Canadian Preterm Birth Network, the Canadian Neonatal Network, Evidence-Based Practice for Improving Quality, or EPIC, the Canadian Neonatal Follow-Up Network, Family Integrated Care, Canadian Association of Neonatal Nurses, European Foundation for the Care of Newborn Infants, and Global Alliance for Newborn Care, or GLANCE. It's only when we all work together that we can put things like this on and advance the practice. Again, you can always go to canadianpreemies.org and watch any of our past editions as well. And there you'll find lots of resources and support and options available there. And you'll be reminded that CPBF is a charitable organization. It depends on support to continue its important work. And as I mentioned earlier, if this is a time of year for you where you purchase gifts for loved ones, then you may want to think about giving a donation in their name and supporting CPBF's mission to empower families of premature babies in every step of their journey. And as we talked about today, that is in NICU and after NICU. Together, we can create a brighter future for all preemies and their families. I hope you're able to join us here next week. We have a very interesting talk scheduled next Friday at 1 p.m. Eastern Time. We're going to be looking at supporting breastfeeding in complex airway patients. So you won't want to miss that. Hope you all have a